Really getting started on alarm management begins with having a good team in place and having the correct data. There are so many alarms and they are so often false or non-actionable that nurses and other clinicians begin to become desensitized to or, ignore alarms. They turn them off. That has led to missed true patient events. So it's really a patient safety issue that we're trying to address.
What are some of the things that are covered in the updated practice alert?
The importance of bringing the interprofessional team together to really look at alarm management is what we focused on.
We are making recommendations both for the bedside clinicians about how they can address the issue of alarm fatigue and alarm management, and then also for people in administrative roles and, other members of the healthcare team, how they can participate in the issue. And basically, we're asking them to think about ways that they can customize alarm settings for patients. That differs depending on what the hospital's policy is on that, but really trying to think about how to individualize alarm settings so that you're not having those non-actionable alarms. Bedside clinicians should pay attention to the electrodes, so making sure that the way that the skin is prepped before electrodes are placed is really important for reducing false alarms. And then from the administrative point of view, ensuring that institutions have a team in place that believes this is an important issue and addresses that, and then is able to get data so they know where their problems lie. What else would you add?
So I'm trying to think other changes in the practice alert. The initial practice alert is very much focused, like Halley said, on the bedside nurse and how they can really manage physiological alarms at the bedside. There isn't a lot of strong evidence out there. A lot of quality improvement and expert opinion on really what should be done. There's a Joint Commission patient safety goal now on alarm management. So we know there's other things being published on what we can do to reduce non-actionable alarms and nuisance alarms. It'd been 3 years since we did the initial practice alert. So we just really scoped through the evidence that's out there and updated it. There wasn't a lot new out there. Still recommendation on changing ECG patch every day, prepping the skin appropriately, how not to prep the skin, because we do know that prepping it incorrectly or with alcohol can actually cause more issues. We also talk a little bit about SpO2, making sure we're using the right sensor on the right body part that it is made for. So making sure we're using a finger sensor on the finger, not on the ear. Research that has been done to show that a finger sensor used on an ear is going to increase nuisance alarms and gives you more false data. And then other things around SpO2 about the warmth and really the circulation of the extremity can make a big difference. There was a study done in anesthesia around the temperature of the finger and how that did lead, the cooler the extremity led to more false alarms around SpO2 monitoring. We know we've done a lot of quality improvement work around alarm management. When we wrote the first practice alert, we then engaged a team and really started looking at our alarms in our adult critical care areas. And by just implementing those standards that we had from the first practice alert, we were able to reduce non-actionable alarms around 75 to 80%.
Oh, wow.
And that really equals the nurse being able to hear the alarms that are going off, because a human brain can only acknowledge so much noise at once. And so when there's so many alarms coming at a person, they actually may not hear the alarm. The other thing, if 90% of the time the alarm is false, you are less likely to respond to it or feel confident that if you need to prioritize things, feel confident that when you look at it, it's going to be actionable.
Yeah, and I was also going to say, we tried to look to see if there were differences in research or the literature around pediatric versus adults. There hasn't been a lot, but we should be thinking about having different patient alarm setting profiles. So for the default configurations that you can select an age range, and it will have default configurations that are appropriate for that age group. And so again, that's another place where having a team of people who are interested and working hard at alarm management is really important. Clinicians as well as people from engineering and more administrative positions, so that you can get those configurations right.
Not only individualizing the alarms for the patient, which is very, very important, but look at your overall default settings that you have for a population and making sure that you don't have duplicate alarms that may go off for, say, high heart rate and tachy. When you're able to pull those things out and share with the end user, the bedside nurses, the respiratory therapists, this is what was happening, and this is why we were getting so many alarms. They understand that. That makes sense to them. So the importance of the why is there in the data.
When you first started doing this, was there any pushback from the nurses? Because they might have thought, well, this is just another thing we're going to have to do.
Oftentimes you run into nurses and sort of describe this as an issue, and so many times we just normalize alarms as part of the ICU environment and say, well, that's just, how it is. But I think bringing awareness to the fact that it actually can be a problem, and it causes this issue of alarm fatigue and missing important events, which obviously no nurse wants to do, but also how alarms impact patients and families. And so I think that once you start sort of helping people to consider what the consequences are of having all these excessive alarms, that's really helpful in getting people engaged. And I think in the practice alert, a lot of what we're recommending as well is not things that the nurse has to do that become sort of burdensome for them. So certainly if there's change in practice with regards to changing electrodes every 24 hours, which some institutions do and some do not, and the evidence is there's some there, but it's not very strong, that really I think nurses will find that that's something that's not incredibly burdensome, but there are other things on there that the nurses actually, they're not involved with at all. So some of the things that we had done, like in some units where PVC alarms aren't important for the patient population, actually defaulting those to off is something that, and from an administrative perspective, can be done kind of on the back end. And nurses notice that the reduction, but that's nothing that was not, something that was burdensome for them. And I guess the same thing for other changes to default configurations. People have tried reducing SpO2 alarm limit from like 89 to 88% has been shown to make a big difference. And increasing a delay from 10 to 15 seconds on an SpO2 alarm, something like that can make a huge difference. And again, isn't something that the nurse is actively doing at the bedside. It's done in the configurations. And so I think, back to Stacy's point, which is just that you have to have the data to be able to see where's the problem and what can you adjust safely to make sure that that we're reducing alarms, but also not missing things.
Right. Now that you did the follow-up, I would hope they would have some really positive feedback for you and appreciation for reducing the number of alarms.
So I think when we initially did our work at my institution, they felt the reduction. As we were able to share the results and the large reduction and excitement in the work that was being done, and that can be very powerful in and of itself. To do this work, it is so imperative that you have the data on your alarms. And that's not always an easy thing to obtain, but having that data really allowed the nurse to see how many alarms they're seeing.
But I think the whole bottom line is the safety of the patient.
Yes,
it really is.
And it's a balancing act.
It
really is.
Yeah. But we can't forget about the nurse too. With the alarm fatigue, because that is real.
Mm-hmm. It is very real. And some of them, it was eye-opening to some nurses to hear that I really am not hearing all that. Nope, your brain really can't take in 15 noises at a time. It's just not possible. And that is something that can easily be going off in a critical care patient's room. How do we really minimize that to a point that you are really going to hear and know that it is actionable and I need to do something about it. A big piece of this work is really partnering with our industry, with our monitoring companies to work together to bring the clinical experts together and the folks building the machines, and how do we make the best machine possible to meet the patient need and keep them safe. And I know Halley's on the AMI committee that it does exactly that. So that's really important work now and in the future as we move forward. So more work that we can do. Yeah.